I am also recording today. And we will also end up with a participant discussion. So as part of housekeeping, we are asking that now the call is being recorded, so just please be mindful of that and ensure that you're not sharing any PHI or information that shouldn't be shared via recording. If you are able to, please type your name, organization, and email into the chat so that we can capture that as part of our evaluation information that we provide to the ECHO platform. Part of that international model. Everything will be recorded and put on our website. So that includes slides, forms, materials, etc. If you'd like to participate in any of the discussions or questions and answers, we ask that you use your raise hand feature so that we can see you clearly. It's also free. You should also jump in if you need to, especially if there's a pause, but we can see you most clearly if you use that feature. Next slide. If you're unfamiliar with AIDPH, we are a 501c3 nonprofit dedicated to advancing the science and education of dental public health. As part of our mission and our vision, our ECHO model follows very closely in our equity work as it relates to education. And to give you a little bit more about the Rural Oral Health ECHO and the ECHO model in general, we, in the past, have been using CareQuest's 3 domains framework, which really emphasizes a teleprevention model, minimally invasive care, and integrated and personalized care. And so internationally, the ECHO model includes sessions that are didactic and discussion-based, which is why we're focused both on the didactic presentation, followed by a robust participant discussion so that participants can take that knowledge back to their communities and implement it more broadly. If you've participated in our previous ECHO sessions, last year, our 2022 ECHO was focused on special topics in rural oral health. For 2023, we're focused on innovations in rural oral health. And so there are 2 things that accompany this, these ECHO sessions. One is continuing education credits for each session. The second piece is the ability to earn a certificate. So last year's sessions are available on demand, and you can complete those sessions for a certificate. And this will start the first of the sessions available in innovations in rural oral health. You can find more information about that on our website. These are the topics that we have planned for this year. And this month is innovations in medical dental integration. If you're, again, new to the ECHO model, these are our standard session norms. The one that I'd like to point out the most is that each person is teaching and each person is learning. So as a participant here, you have a value and a voice to this ultimate discussion. We tend to use first names so that everybody feels comfortable adding their perspective to the discussion. And we encourage everybody to use their pronouns in their Zoom name so that we can be respectful and mindful. And so with that, I'd like to turn it over to Cassie Harter. Cassie Harter is a seasoned dental hygienist and public health professional. She received her Bachelor's of Science in Dental Hygiene from the University of Michigan in 2012 and her Master's in Public Health from the University of Washington in 2020, where she completed her thesis on the project that you'll be learning about today. Cassie also served as a research coordinator at the University of Washington School of Dentistry for Oral Health Access. Projects taking place in Southeast Alaska and rural areas of Washington state. She participated in those projects. She led an oral health collective impact network in Pierce County, Washington, where she co-developed medical dental integration projects, as well as coordination to address access to care locally. Since she's moved back to her home state of Michigan, where she will continue her public health practice after leaving Washington. Cassie is a member of the American Dental Hygiene Association and active in her local component in West Michigan. So please join me in welcoming Cassie. And Cassie, I will turn it over to you.
Thank you, Annalise, and hello, everyone. So you'll see my real name is Catherine, but I do go by Cassie. So, for purposes of this meeting, feel free to just call me Cassie. Super excited to share my work with you all today. And Annalise kind of already mentioned this, but I do want to state that this body of work was developed and completed as my graduate master's thesis from the University of Washington School of Public Health in 2020. And I also want to state that since this work was published in 2021, I've been slightly removed from this since then. So just to keep it clear, I was not personally involved in the project, but I did evaluate it at a point in time. And that's what you're going to hear about today. So let's jump in. So the title of the project and the body of work is Medical Dental Integration in a Rural Community Health Center, a Qualitative Program Evaluation. Authors include myself, Dr. Joanna Cunha Cruz, and Dr. Kirsten Centuria. They were both faculty at University of Washington at the time. Dr. Juliana Helgert, she was visiting faculty from Brazil, and then Dr. Stephen Davis and Mark Code from the Yakima Valley Farm Workers Clinic. Go ahead, next slide. So this project was based in Washington State. It's a big state. I know I saw one Washington person at least here, but it's a big state geographically and diverse with some vast rural regions. And this project in specific was taking place in a rural area in Eastern Washington, serving mostly migrant farm workers and their families, where most of the folks identify as Hispanic. And I've updated this data since the research article was published in 2021. So if you happen to read that, the numbers are slightly different now. But to kind of set the scene, nationally, according to NHANES data, the dental caries prevalence is especially high in Hispanic youth, with over 50% of kids kind of having that caries experience. And in Washington specifically, over half of the third graders have had a history of dental disease. And particularly in the county where this project takes place, it is the county with the second highest rate of dental caries among third graders. And then in at least 34 out of 39 counties in the state, they don't have enough dental providers to meet needs. So according to HRSA, Washington would really require probably around like 300 plus providers to remove that status as a designated health professional shortage area for dental care. So some of this information I expect isn't especially maybe surprising to you. You know, you may not live in the state or be familiar, but unfortunately the status here might look similar to your own state or locale. So go ahead, next slide. So I suspect most of you, or maybe even all of you, understand at least a part of what medical dental integration is, but you know, as a review, this is one way, you know, healthcare administrators and providers are attempting to really bridge that gap between medical and dental direct services, right? It's more than just co-located clinics. It requires really organizational and system changes to engage and diversify the workforce. It's changing administrative and clinical practices. You know, the current health system, it's not set up to communicate or collaborate efficiently. So now a lot of different types of projects and strategies are being talked about and piloted to see what works, and attempting to get, you know, I think at each of these features of integration. Next slide. So now that you have a little bit of background and context, we'll dive into the research part of it. So this was our official research aim. So we're really all about bringing about the perspectives and experiences of those who were involved in the project, to figure out if people liked it, what they liked about it, you know, what made it work, what made it hard to implement, and was it successful, you know, whatever that may mean to the group who implemented it. Next slide. So the project itself started as a pilot program in 2018, aimed really to expand access to care. You know, it includes 2 full-time dental hygienists trained as community dental health coordinators, which, if that's a new term for you, it's a American Dental Association training program, and I can totally share info on that if that's a new concept. Just holler at me in the chat if you'd like me to share. But those hygienists worked with the medical teams in 2 separate, pediatric medical clinics. So same organization, but different locations in different medical teams. And they were performing oral health assessments, caries risk score, health promotion education, fluoride varnish, care coordination, and dental referrals, obviously, when necessary. And this was all done during well child visits for their target population of children 0 to 5 years old. And these were all, again, these things were all being done alongside other providers, such as like a nutritionist, a behavioral health specialist, obviously the pediatrician and their nurses and MAs and such. But I do want to clarify though one thing. So although their target population was early childhood, if they had time and the schedule would allow, they would definitely see children up to the age of 18. But the priority was really that early childhood, the 0 to 5-year-olds. Next slide. So I will not spend a ton of time on data collection, so exciting, but our methodology, it was a qualitative study. So, and we actually originally had planned to include patients and caregivers, but it was like high time for COVID. It was spring of 2020 when these phone interviews were taking place. So that was next to impossible. But you can see here that we spoke to, a spread of dental providers, medical providers, and clinical administrators, all who had been there for various amounts of time. Next slide. And just a few other notes on methodology. Our interview guide was based on the AHRQ's agency. So that's the Agency for Healthcare Research and Quality, their Atlas of Integrated Behavioral Healthcare Quality Measures framework, which I will definitely get more into in just a moment. But just want to share another point that explains, the strategies that we use to systematically analyze the data. Next slide. So to get into that framework, so this is a visual that I constructed, not the AHRQ, but I just like it because it's a simpler visual of the 10 domains that we based our questions on for presentation purposes. Like I said, this framework is from the AHRQ's functional domains, it's like a mouthful, functional domains of care integration for behavioral health and primary care. So we just adapted it for dentistry. And I think once I explain it a little bit, you'll see it applies just really well. So let me explain each domain in a little bit more detail here. So when we're talking about care expertise, we asked questions like, if the team was properly trained, knew what their role was, if they felt that they were competent in the services that they were providing. Clinical workflow, really asking, how each person's day-to-day flow was affected. Was it a smooth transition to add this person? Was it clunky? Those types of things. Patient identification, we wanted to know how they determined what patients the hygienist would see. Treatment monitoring, we were asking about, what services did patients receive, and then how did they utilize monitoring to really follow up on care if it was necessary, like if they saw a patient, and they had to go see the dentist or something, how did they follow up on that? So just treatment monitoring. And then operational reliability. So this has more to do with like what systems were in place, or what systems needed to be in place for this program to like work smoothly and logistically. So for example, what was needed in the electronic health record, to input treatment or documentation, or did there need to be stand-in check-in meetings now that there was a new person in, those type of things. Data collection and use. So similar to treatment monitoring, not so similar in that it's more about like general numbers, demographics, kind of that macro data and information, like how many patients were referred to dental, how many patients were seen by the hygienist, how would they be using data to shape the program further, those types of things. And leadership alignment, we asked, was leadership supportive? Were they on the same page? What about leadership maybe helped or hindered the implementation of the project? Patient family engagement, how were patients notified or like educated about it? Did they understand what was going on in the appointments? They're just like, there's another person, One thing we did not include, and you'll see it's kind of highlighted differently than the others, is that business model sustainability. Basically, the reason we didn't include that is because they were already doing, the clinic was already doing an internal audit of that, for funding and financial reasons. So we didn't feel the need to tap into that. And then obviously, lastly, desired outcomes. I think that's pretty self-explanatory. Did things happen like you wanted them to? So again, we use these domains to prepare interview questions, but this framework is actually intended for, and I would assume is extremely useful for, practical application for folks who are either actively trying to plan and implement an integrated care model, and or performing their own internal evaluations, right? So this kind of walks you through the steps, and it almost acts like a checklist for what you need to have in place to implement an integration program. This framework is totally publicly available. It's located on their website. I can share the link also to that if you'd like. It is down there in the corner, but it's super small. So holler at me in the chat again if you want to link to that. But they've got user guides and content to really shepherd people along going through this process of integrating things like this in their clinical spaces. So pretty cool, pretty useful. Next slide. So our data revealed 3 major themes, each kind of with their own sub-themes. So first, the MDI, I refer to medical dental integration as MDI because it is a mouthful. But so the MDI project is feasible and it's acceptable with some considerations. And those considerations include this particular clinic. So this clinic was able to integrate the electronic health record. They utilize Epic and then a product called Wisdom that, that's the dental version of Epic. So they're allowed to kind of work within the medical platform. So that was really helpful. The familiarity of service integration among the providers, right? So they were already used to multiple providers in these well child visits, like coming in and out of their appointments. It wasn't just one person. So the workflow wasn't totally brand new to be adding another person like the hygienist. Progressive leadership within the organization. They typically, they weren't, afraid to kind of look outside the box. They were willing to try new things to increase access. So that proved as a huge facilitator. Clear communication once the project got going among the departments, that was really helpful. And then the fact that they utilize the dental hygienist as the integrated provider. And something to take note of here is that, so this organization utilized dental hygienists not only because they're billable providers and it kind of made sense billing wise, but these individuals in particular were extremely internally motivated and passionate about access to care issues. But maybe even more importantly, these providers were from the community. They shared culture and language with their patients, and you cannot teach that. So I do think, that's important to keep in mind, maybe if nothing else from this presentation. Second theme, implementation, of course, faced some barriers and challenges, right? So these barriers included, there were some initial reimbursement challenges with Medicaid, but since then that has been ameliorated by there's a specific program in Washington State for dental care reimbursement for providers. It's called the ABCD program. I won't get too far into it here, but again, I know someone on this call can share that info with us. So if you want to go ahead and pop that in the chat, I think people would be interested in hearing about that, but that makes a big difference. They had some initial planning phase miscommunication, which is to be expected. And then actually some discrepancies in the demand for services between the clinics. One clinic was actually much busier than the other. So that kind of made planning and data collection and things like that just a little less cohesive. So yeah, so those are kind of some barriers. And then thirdly, kind of a big theme that came out was this project was perceived as beneficial and successful in terms of like patient outcomes, services provided, increased access to care. People noted that patients were being seen for the first time by a dental provider. Parents were happy to have a dental provider look at their kid. They were getting seen quicker by the dentist because, they were able to make that warm handoff, and they didn't have to delay that urgent care. So I do have a quick quote that illustrates that point. So go ahead and pop to the next slide. And I have a lot of meaty quotes from the interviews, but I'm only going to share one in the interest of time here. But one medical provider noted, there was an instance where I had a patient. I was very concerned about a dental abscess, which is not something we get a ton of training on. I said, okay, I'm going to have to go to the dental hygienist, have her come in, take a look. And we were able to connect them upstairs to get an appointment upstairs, is where their dental clinic is. Get an appointment upstairs right away to take care of things. Otherwise, would that have happened that day? Probably, but it would have taken me going out of the room walking upstairs, finding a provider, and 15 minutes later, I'm back on the floor and I have 3 patients waiting for me. So I like this quote because I think it also speaks to a common response, what a common response might be to adding another provider um, to the wild child visits, right? Like, we don't have enough time, please don't add anything else to our plates. But in this case, it didn't take up time. It actually freed up medical providers' times with their patients. So they didn't have to address these issues themselves anymore. That's on the hygienist. So it actually improved efficiency. Next slide. So I think some key takeaways here are, this particular model of integration is acceptable and feasible in this rural health setting, kind of by all participants, right? So sometimes these models are only championed, by one party. And in this case, while maybe not at first, all the parties are on board and supportive, at least in the clinic side of things. Also, this, although the model may be acceptable, if reimbursements don't follow, these services, the program may not be able to last long term. So really, economic aspects need to be considered for sure. Also, well child checks seem to be a pretty natural appointment time to embed oral health services, at least in the pediatric population. Multiple providers are already expected to come into the appointment, not only by patients, but by the providers themselves. So that kind of helped make care more efficient and more accessible. And then lastly, this model of MDI of embedding that dental hygienist, particularly culturally aligned hygienists, may contribute to kind of that positive perception of the project. And I say this totally just because in our literature review, previous studies that didn't incorporate a provider with formal dental education, like a dental hygienist, like a dental therapist, to provide the oral health services, they noted barriers like kind of lack of oral health knowledge, training, some lack of confidence in performing the oral health services. And those barriers just didn't come up here, right? But I know there are many forms and models of integration. I'm totally not saying this is the best one, but I'm just saying, this data in this study presented as these particular providers as a facilitator to this project and this implementation. Next slide. And so, yeah, to wrap up, I just wanted to give some concluding thoughts and some next steps. I think first, obviously, medical dental integration it's needed to increase access to dental services. I think we're all aware of the fragmented health system. We're leaving people in the dust health-wise, and with the silos that exist. Next, this particular model of incorporating the dental professional into the medical practice is accepted by both providers and administrators. And sometimes it's hard to get everyone on that same page. So I think that's noteworthy. But also, in terms of future planning, we should really be using the results of this study and other studies to inform some additional larger scale research to really confirm or contradict these findings as they would apply to some other sites across the country. I think in this research, it's pretty applicable to this particular site. It would be interesting to see how that works in other sites. And then lastly, I think we need to understand some long-term outcomes of integrated services, right? So for patients specifically, how it may influence or possibly reduce healthcare inequities to really promote policy development for some system-wide changes. I know we want to assume it will all have a positive impact on people, but in order to really move policy and legislation, we really got to get that outcome data to see if we've changed something, if we move the needle. So last slide. I just want to thank all of my co-authors who made the project possible, Yakima Valley Farm Workers Clinic for accepting this project, and our Cora Foundation, Dental Foundation in Washington for connecting us. So yeah, thank you all for your time and attention. I hope there's time for questions if you have any.
Wonderful. Thank you so much, Cassie. We appreciate the presentation, and I would love to invite some questions for Cassie. Any follow-up clarifications or comments? So Cassie, I have a question that kind of piqued my interest as you were going through your slides. It sounds like in the community center that you are evaluating these data in this rural area. It looks like this medical dental integration framework works best and maybe has the most most facilitators and fewest barriers in a co-located setting. And
Mhm.
so is this something that you feel like is maybe more feasible in rural settings because those community health centers are often have kind of like co-located spaces where medical and dental are together? And if it wasn't co-located, do you feel like it could have been, if there are aspects of it that could have translated into a non-co-located environment to expedite care?
Yeah. So I think for sure, the reason part of and as a researcher, having my researcher hat on, I have to make sure I'm not like, this was the best, model. It just like, these are the results we found. But, I think definitely the aspects that made it successful is the fact that logistically when a hygienist maybe identified something as this is urgent, this is active decay, this is an active infection, being able to run upstairs or call, like, because these hygienists were still connected to the dental clinic, in that they were kind of the care coordinator, perhaps, to get folks upstairs. So just like physically being able to say, here you are, go right here, it's right here, and I know a lot of dental clinics keep spaces for emergencies. That was kind of a seamless situation. So of course, if they weren't located, maybe that particular aspect wouldn't have been able to happen. But I wouldn't say, don't do it if you're not co-located. That's crazy, because it all just depends on the relationship, I think, between the clinics and that communication. Also having the electronic health history and records kind of communicating with each other, that was huge. So that could happen at non co-located areas, where you could still say, hey, so and so has an appointment for you over there, I wanted you to scoot on over, it's 5 or 10 minutes or however long away. You need to get over there now, and they've got a spot for you. So there's aspects, of course, that made it a little bit easier being co-located, but I definitely think you could still have some good success, even if they weren't.
Wonderful. Deidre, I know you added something into the chat about any advice on how to boost medical provider buy-in, which seemed to be a really big facilitator here.
Yeah.
And I don't know, I'll add too, if there's anything in particular that we should consider in a rural environment, if there are like something in particular that rural medical providers had engagement or buy-in, and that we could borrow something from those successes.
So I'm going to speak on my interpretation, but I don't work at this clinic. I don't work directly with the medical or dental providers. So I just want that to be clear. But what I would say is this organization, I think from its kind of inception, was like, we're all hands on deck. And, I know it's such a hard one, because it's so kind of inherent in their models and in their workflows and in their thoughts on how they're serving their populations, that's tough to change. I mean, that's tough to kind of show, hey, this is important. That's what I was saying is, like, the fact that all these folks were on board is like wild. Maybe not wild, but just incredible. Maybe that's a better word for it. How to boost medical provider buy-in. I mean, one of the things in this is going to be long term. This is long term outcome data. But one of the things that you can do in the immediate is, there's research out there that the more preventative visits you have, the more you're saving money and time down the road. I think we, at least a chunk of us in here, is like, saving people from going to the ER, dental related ER visits would save us all money down the road and save us all time and all of that. So I think just being able to come at it, sometimes people need a financial reason why this is important. Some people need, emotional reason why, to do things, but I think being able to show them there is research out there that says, the more we integrate care, the more we close the gaps, the more we're saving everyone time and money, and obviously improving health. So that's what I would say, without being, like I said, without being an employee of that health center.
That's great, Cassie. I really appreciate that additional insight. It sounds like culture
Mhm.
and it's a really big aspect, and having that existing culture of wanting to really work together is a key facilitator. So I also want to ensure that we're saving time for our case discussion or think tank discussion. And I know there's a couple of comments and questions in the chat. So if it's okay, I'm going to invite Cassie to respond there. And also, I'm sure she would be happy to follow up with folks afterwards. And with that, I will turn it over to Christina Demopoulos, who is our think tank presenter today. Associate Professor Christina Demopoulos joined UNLV School of Dental Medicine during fall 2001 and teaches public health, tobacco cessation, health promotion, behavioral sciences, and access to care topics within the pre-doctoral dental program. She also provides information about tobacco cessation and access to care within the postgraduate pediatric dental program. Dr. Demopoulos' research focuses on improving the health of diverse populations, and her current work focuses on improving the health of newborn to 5-year-olds within early Head Start and Head Start centers in Nevada. The project involves other states and aims to identify what factors may contribute to increased oral health risks among this population. And it also seeks to identify which evidence-based health promotion strategies can be implemented in these centers to improve the overall health of kids and their families. Dr. Demopoulos is actively involved with a variety of other projects that have been implemented in school and community-based settings. And so with that, I'll turn it over to you, Christina.
Thank you, Annalise. And thank you for the opportunity to offer this case presentation or discussion for our think tank and our wonderful participants today. So a little bit about the background for Nevada. We only have 17 counties, but based on our most current report, which was the fall of 2022 from the primary care office in Carson City, all 17 had a provider shortage designation based on the population to provider ratio. And we at the UNLV School of Dental Medicine, which is in Clark County, Nevada, is the only dental school. So our aim is to actually try and improve upon the educational opportunities for our students so that they could actually help offset part of this ratio. And more specifically, in the rural and frontier areas, the travel time to get to a dental provider can take several hours. So many of you probably have similar concerns or barriers within your respective states, but with us being in Las Vegas with a dental school, imagine how far people would have to go if they don't have a dental provider in their respective community. Next slide, please. And more than 1 million people live in those designated shortage areas. Specifically in Nevada, we have 70 that the primary care office has identified as health professional shortage areas specific for dental care. And only about 30% of those that live there, so only about 30% of the million have their dental needs met, which means the 70% do not have their dental needs met, meaning maybe the barriers are too great, the resources are too difficult to access, or just surely they cannot get into a vehicle to commute to that dental provider. And about 190 additional providers are needed to remove this designation. So our primary care office and the same ones across the country, every 3 to 5 years, will let you know about how which providers are in which respective counties, but also how we can offset these shortages. So for us, physically, we would need an additional 190 to remove the shortage. So you can see we need a lot more providers licensed in the state providing the care in these rural and frontier communities. So it's important for us at the dental school to provide the educational opportunities so that hopefully some of our dental students go off to a residency program or even just practice within the state of Nevada, just creating the awareness of the need. Next slide, please. So what our current proposed plan of action is, we want to conduct a curriculum review, just looking at our public health curriculum, more specifically dental public health curriculum, to see if there are any gaps on how we can improve upon the knowledge and awareness for our students and our respective faculty. And then subsequently, we want to look at the community-based experiences for our students in the underserved communities, specifically in Clark County and the rural frontier areas, which is where it gets into our discussion question. Next slide, please. So what I'm asking our group or think tank discussion would be, what strategies can we at the UNLV School of Dental Medicine employ to provide educational opportunities for our pre-doctoral dental students to create awareness of the needs of underserved and vulnerable populations? I think that was it. Next, I think, yeah. So Annalise, I'll turn it back to you so we can facilitate the discussion with our small groups.
Absolutely. So the first thing that we'll ask with everybody together is just if there are any clarifying questions, and then we'll move into brainstorming. So I invite folks to come off mute if you'd like to ask Christina directly any questions for clarification. So that way the whole group benefits from anything that would be helpful from that perspective. You can also pop it into the chat, but we'd love to have more voices in the room too.
I do have a quick question. Thank you, Christina. With your with the dental school in Nevada, do you, and I know you were talking about pre-doctoral dental program, but just because I'm curious, do you also have a dental hygiene program or just dental program at your school?
Oh, good question, Carolyn. The dental school has just a dental school program. We do employ licensed dental hygienists to provide our curriculum, but just up the street within the Nevada System of Higher Education, we do have a dental hygiene program in Las Vegas. It's just not affiliated with the dental school, but we do a lot of collaborative projects together.
Absolutely. And that's why I was asking. I was thinking like, what kind of collaborative strategies do we have? Awesome. Thank you.
Yes, very, very good question, because yes, it's a wonderful workforce that we can tap into.
It sounds like Colleen had a question in the chat that's kind of similar in that she wanted to know if there are other state health departments or different divisions like rural health that you could potentially also tap into.
Thank you. Good question. We do work with our Division of Public and Behavioral Health, which would be our state health department. And within that, there is an oral health program. And within that, they're trying to leverage resources with chronic disease prevention. So I think that's a great question, follow-up, to actually work closer to the state. Since we are the only dental school, it doesn't mean that we're the only oral health providers. The state does have a public health endorsed dental hygienist working and a state dental health officer that's doing wonderful work across the state. So perhaps working closer with them to address some of these gaps or concerns, I think would be wonderful. Thank you, Helene.
Okay, perfect.
Christina, sorry, Annalise.
No, go ahead.
I'm just curious if the students, if you have set up rotations, clinical rotations through any of the community health centers, are they getting their feet wet going through on rotations?
So right now, the only rotations we're having is through schools in the Clark County, which is Las Vegas community. This would be the first attempt to actually get them into more community-based settings. Now, us as faculty with dental hygienists have been traveling the state doing work. So we do have somewhat of an infrastructure in terms of collaborations with FQHCs, community clinics, Head Start centers. But this will be the first time our pre-dental students would venture out of the actual Clark County, Las Vegas community. They have participated in RAM, so remote area medical, in a couple of our rural communities the last couple of years. So some of them have gotten their feet wet, as you've said, Kim, but this will be full-blown rotations for all 80, 85 of our students every year.
That's great. Helene, I'll invite you to have the last clarifying question before we go into breakout rooms.
I'm sorry, I've been juggling between two meetings because I can't figure out time zones. One of the other suggestions I was going to make, and I don't know if any of you are working with your regional CFAR, Center for AIDS Research, and even though that's more HIV directed, they do have a lot of access to vulnerable populations because many of the community organizations they work with are not HIV dedicated. And I know from our CFAR up here that I'm involved in, we also have an opportunity to review potential grant submissions. for people. So if you were considering applying for something, or even applying to a CFARS and you investigate or on some kind of pilot program, that's something I think to be considered.
Thank you, Helene. And we actually do have the pre-doc HRSA grant. This is our first planning year, so this would be one of our deliverables as part of our HRSA funding cycle. So yes, leveraging maybe the federal funding with perhaps state funding to meet the needs would also be great. Thank you. Good job. Thanks, Helene.
Okay, wonderful. So we'd like to open up 2 breakout rooms. Some of you will be staying here in the main session with me. Others will either be with Caroline or Zill as facilitators. And just a prompt, please, to record in the breakout rooms, for facilitators to record in the breakout rooms. And the reason why we do that specifically is so that everybody has a chance to contribute. Like we said, for our all teach, all learn model, we would love folks to turn on their cameras. Please add your voice to the discussion and the brainstorming that we'll do for Caroline's, or I'm sorry, for Christina's question that was popped into the chat by the other Christina. So with that, you should get a prompt soon to go into your breakout room, or you'll just be staying here in the main session. Okay, perfect. So I'll just invite folks to turn on their camera so that we can get everybody's perspectives represented here as part of this all teach, all learn model. And I'm going to copy and paste the 3 questions that we're brainstorming today into the chat. Number 1 is, how can we solve the problem? Number 2 is, how can we think about it differently? And number 3 is, one more person, who or what is missing from the table? So again, the ask of the group is, what strategies can UNLV School of Dental Medicine employ to provide educational opportunities for pre-doctoral dental students to create awareness of the needs of underserved populations? So what comes to mind for folks?
Annalise, I'm just taking a minute to get familiar with the questions again, because I was answering some other questions. So I'm just reading. So I'll join in just a second.
That's okay. Please take your time. And we have the benefit too of having Christina in the room with us. So, you know, she's still available for any clarifying questions as you read through.
And Annalise, there was, I think we switched to small groups. There was a comment in the chat from Arizona about having rotations for their DS3 and DS4 students, specifically with federally qualified health centers where maybe there would already be that infrastructure. So I wanted to share that. I think it kind of went up in the chat, but it posted right before we broke out.
That's exactly what I was going to say, because we have a School of Dentistry here in Maine, University of New England School of Dental Medicine, and I work for the Primary Care Association. So we do have those students going out to rotations at the health centers. My other thought is if there's any type of community events that could be developed where they could go and do screenings, assessments, provide education, specifically, you know, in the communities that would be getting them exposed more to patients of this type.
Thank you, Beth. And we do within our 3rd year course, I'm the course director. Each of our 3rd year students is required to do 15 hours of community service, most of which are within Clark County or the rural areas slightly beyond our doors, like within an hour driving, but not as far as what I would hope to venture out into, like the Elko area, the Tonopah area. The areas are like 3 to 5, maybe even 6 hours away. But we have wet our feet initially, preventive dental services, screenings, fluoride, and then within schools, we do oral health education, nutrition, and sealants. So more of the preventive side. I would just like to see that a little bit more robust with even more preventive services in rural frontier lands, but also some restorative if possible. Collaborating with the Primary Care Association, I think would be wonderful. If they already oversee these FQHCs, perhaps they can help us get some of the conversation going.
Absolutely. If they have an oral health program manager like myself, that might be the person that you'd want to contact and see about coordinating it. Ironically, before I joined the Primary Care Association 3 years ago today, as a matter of fact,
Okay, good.
I was managing dental practices and we had an advanced education in general dentistry residency program. And one of the things that I did was to help get them set up and go on their rotations and work with all the specialists.
Oh, wonderful. Thank you, Beth.
You're welcome.
Yeah, I would piggyback off of all the things that have been said. I just remember, at least from my hygiene education, so we were with ourselves and dental students. I'm not sure what your institution does, but even our 3rd and 4th years, we were doing local FQHCs and CHC rotations. And then in our last years, and the hygienist and dentist would have to do the same things. The school would work it all out for us, but we'd have a rented car, we'd go to a hotel, we'd drive to the really rural parts of Michigan and stay for a whole week and be working alongside the folks who are at these FQHCs in the dental clinics. And to me, you can read all you want about disparities and data and like this is what's happening until you see it, and until you are in those mouths or in those situations and seeing the other services that are at those FQHCs and why those folks need wraparound services. It was just like, that's the reason I went into public health eventually. So
It's so good to hear. And we actually do presentations to try to get people to understand what FQHCs are.
That too. Yeah.
And integrating the care still, even though they're housed in the same buildings often, is still challenging because, I was picking up on what you were saying about your electronic health record. And I'm like, oh, yes, that's right. We have Epic and Wisdom. So.
Yes. Well, and I remember I had one patient, the blood pressure was way too high and I couldn't do anything. And they're like, oh, try and go down. I was like, should I go down to medical? Should I ask that? And they're like, you can try, and it was just like a situation I couldn't see, so there's just so much exposure that like, you can't ignore it. It's like the Matrix. Once you take I can't remember if it's the red pill or blue pill, but once you take the pill, you can't unsee it. So, yeah.
Thank you, Cassie. And that was what I was hoping, because I did my dental training at USC in California, and it was all, a lot of mobile clinics. So going out into the farmlands, rural communities, which is why I chose to go into dental public health. But I was hoping that if we offer these experiences to students, they would also get this passion for public health and eventually go back. So that's where I am. I'm on my little soapbox. I want more people to go into the profession and eventually, like I said, not only provide the services, but perhaps even join our dental public health residency in the future. So I want to create the experience, but I also want to create maybe educational opportunities to further their education in public health.
Christina, I'm curious if you guys have thought about or have access to, so I guess 2 things came to mind as I'm thinking about medical dental integration, our topic for today, is whether or not you have access to like a community health worker program. Here in Texas, they're called promotoras. So it's like a very culturally specific thing. But to Cassie's point earlier, she noted in her research that that cultural aspect of having the dental hygienist be a part of the rural community was a major facilitator. So I'm curious if there are any opportunities in those rural communities to learn from like a community health worker or develop a partnership so that students could have some of those non-traditional experiences that are in real life, but not necessarily clinical.
So we have community health worker models and programs within the Nevada system of higher education. We don't employ any within the Nevada system of higher education, but they are in the community. One of the benefits we have, and I'm sure other states have, is community health nurses. So it follows the same kind of model, Annalise, and they're trained to do screenings and caries risk assessments and fluoride varnish. And there is a network that reports to the state of all the community health nurses. That's not to say that we cannot hire community health worker, because when I used to be the state dental director, I used to train the community health workers on oral health. So I know they're out there in the state of Nevada. We just have to be able to hire somebody. So I think that's wonderful. We do have a social work practicum student within the dental school that kind of talks about some of the barriers for our patients. And if there is a barrier, our students know to go to the social worker. But I like the idea of actually being able to work specifically with a community clinic, with a community health worker that understands oral health, or at least is interested in understanding oral health concerns.
Yeah, it came to mind. Oh, I was just, oh, sorry, I'll have one more comment that it came to mind because when we were doing our school-based salient program, and I know that you have a lot of familiarity with that in Nevada, we had dental students rotate through that. And a lot of times they didn't understand what it was like to navigate folks into care. And we actually had community health workers do that. And our students would sit alongside them as they would call people up and say, hey, we noticed you had an urgent dental need. How can we get you into this community health center? Just even overhearing those conversations was really helpful. And I think that I'm curious if that's attainable from a student perspective too. Like if we're thinking about pre-doctoral students, just being involved in those conversations could be, even if they did that via Zoom or something like that, it could add a really interesting aspect to their education in your curriculum.
Thank you. I appreciate that. I agree.
What I was going to share is that here in Maine, there's some things that are taking place with in conjunction with the CDC as well, about like oral health navigators and various other things, people in the community to kind of broaden that network and maybe facilitate some of those connections. And there's also a lot of equity work being done in the BIPOC communities, more in the southern part of our state with community health workers. So we're definitely looking at the model of a community oral health worker, kind of bringing all that together.
Thank you, Beth. I know we have our state and local Office of Minority Affairs that is trying to hire some navigators. They were hired originally to help navigate the Medicaid system, or at least the opportunity to become Medicaid eligible. So maybe they actually have their feet on the ground, so to speak, about trying to provide some of the education, and that would be a very, very diverse population that they serve across the country. So I think it ties into what Beth said. Thank you.
Mm-hmm.
One thing, Christina, and I don't know if somebody brought this up, but this is more kind of going to upstream, but eventually maybe something the school could do is recruit students out of some of these areas, or students from the, like I was saying in the presentation, taking folks from the community, because then the idea is hopefully they'll want to go back or give back or what have you, and they're, like I said, inherently sharing culture, sharing language, sharing things with this community, and will feel tied and have built-in trust already. So like I said, that's a little more upstream, but dedicating some time of the university's resources to recruiting people specifically from those areas.
Thank you, Cassie. I appreciate it. Yeah, we've done a lot of work in different parts of the state, and every once in a while when a student applies, like, oh, I know where that county is, it's that small county somewhere in Nevada. And I think that's wonderful. We could actually actively get out there and recruit more of them. It would be more than just a couple here and there. It'd be a more robust group of our pre-doc students. So thank you, Cassie.
Yeah, along the same lines as what Cassie was talking about. I'm with the American Dental Association, and I think it's more than a few years ago now, there was a pilot program that I worked on looking at community health or community dental health coordinators, so CDHC. And it was, so I'm sure you all are familiar with that, but that's what came to mind for me as well, in terms of thinking about pulling people in from the community. And then just, getting students immersed in the community and seeing those needs in person. So
thank you, Rebecca. Yeah, so to actually employ somebody with the training that they've gone through. So that would be wonderful. Thank you.
It's a great idea. Okay, well, our breakout rooms are closing and folks are trickling back in. So we'll give everybody a second to rejoin. Okay, so I'd love to just invite super brief because we're close to time. So if the facilitators of the breakout rooms can maybe give us a 30-second overview of some of the key learnings in your breakout room, that would be lovely. And Caroline, I'll call on you first.
Absolutely, that sounds good. So I think one of the main things that came up in our room was really creating robust community partnerships to allow dental students to be able to go into the community to get experiences with these vulnerable populations and also be able to help improve access to care. That, you know, is an issue, like you said, Christina, in your state. But I thought the cool part was that we didn't just talk about, oh, like the Head Start centers or the FQHCs. There's a really good suggestion in our group to think outside the box about community partners that you work with. I think a really great example that was said was think about a church that may have a help ministry where the dental students could potentially volunteer or set up some sort of rotation where they can go and meet the communities where they are in the spaces where they're comfortable to build trust, to also get these experiences. So that's something I really, really appreciated. And just to round everything out, after the students have these experiences, community partnerships are created, they have these experiences, just making sure the students have space when they do come back together to share with their peers what they learned. And that way they can celebrate wins, talk about challenges, and really continue the work together as a group.
Thank you,
Yeah.
Carolyn and the group. The wonderful suggestions. Thank you.
Sil, can I turn it over to you for a brief report out?
Yeah, well, Caroline kind of stole my thunder because I was going to go down a little bit of a community partnership pipeline. But we would also, our group talked a little bit about ways that you could partner with other universities. As you noted, that it seems like you're the only dental school in the entire state, but looking at regionally ways that you can look at other state programs and trying to get that before they're in the dental school pipeline, as well as looking at some remote sites as well, as ways to engage the students if they're not going to be able to go into the communities immediately, looking at some ways to do satellite campuses, as well as we talked about some comparative models at other universities as well. So the notes will reflect some of those then more in detail.
Thank you. Very creative. Thank you.
That's perfect. Thank you all so much for this important conversation. And we'll just call up our last slide as a couple of reminders closing out today. Number one, CEUs are available for today's session. And in fact, I put the link in the chat because we are really streamlining the way that we provide CEUs. You will have the CEU link that should pop up immediately after this session. Please use that link and evaluate. It will expire in 2 days. It should have also been included in your confirmation email, and it's also in the chat. So these are the times for you to use the link to both evaluate and request CEUs. We are recording this, and the recording will be available for our certificate series this year for Innovations in Rural Oral Health. You can also watch the recordings 8 sessions from last year for special topics in rural oral health. We invite you to join us April 20th for our next session, which will be Innovations in Rural Oral Health Workforce. And with that, I will thank you all for your participation today, and we'll see you next month.